regarding our safety net funding from our friends at the health department. So just a little housekeeping to remind everyone that the communications that come out from Michelle Randall, that it's really important to read them. There's good information in there. And to remind everyone that every quarter you do get a new RR to fill out. So it changes each quarter because she does updates and things to them. So not to use the old form, the new form comes out and to use that one. Okay. And then to ask, we have not had any issues this in filing or getting paid or any questions, but the floor is open to see if anyone has any direct questions to the paperwork, which is electronic work now, I guess we call it. No, everybody's good. Okay. And then with the formulary, was there any questions regarding any of those codes, procedures, how to use them? I think they were pretty comprehensive. Nobody's reached out to me about a change with them. So, okay. So,
Dan, did you get it?
So I think we can use our time wisely then for those on the group, since no one has any concerns with it. Talking about, how to maximize the appointments. So making that encounter have as much in it as possible. Of course, it doesn't increase your payment the more you do in the encounter, but it is much better for our patients, of course. And so many of them travel so many miles and have so many barriers to getting in. When we've got them in the chair, we've got to do as many things as possible. And as administrators, we have to do more than gently encourage our provider teams to do these things. It is something we struggle with, not motivation by providers, but it all goes down to proper scheduling, right? How much time is allotted? If you run out of time and you could have done more things, then you're wasting a trip. And each, new encounter has so many more costs attached to it, rather than just what you do in the chair, like all the front desk costs and, all the things that it does, a whole new set of infection control, all those kinds of things. So the more you can do per visit. So does anyone have any ways they have been effective in thinking about how you schedule? And, the problem that we run into, if you schedule a long appointment, like let's say 2 hours, because someone's coming from very far away and they have a lot of need. And then if they don't end up making it to the appointment, now you've got this 2-hour time block rather than, an hour that you have to fill. So that is what makes it really challenging. So how are some of you addressing that?
We frequently were asked people when they call for appointments if they would be available on quick notice. That just happened late yesterday, as a matter of fact. We had a patient that called in and they wanted an appointment, and the earliest we had was like 2 weeks out. But we said, if we have a cancellation on Friday this week, would you be able to come in? They said, yes, they would. So we try to see if they would be able to come in quickly. But we're still having people stay in their cars in the parking lot, still taking their temperatures when they come in. So we're still working under the COVID rules, so to speak.
Mm-hmm. Yeah. So are your patients able to come at quick call? We don't have very good success with the quick call list. Seems like it takes so much arranging for them to.
Yeah. Well, your patient base is much more spread out than ours is, I'm sure.
So the quick call really works. And do you text them, or you're
a phone call,
phoning and able to do it?
Right.
We do the same thing too, Rhonda. We keep a
a handwritten list by the phone and designate if someone lives close by and if they're able to come in, if they have more flexible hours with their work schedule. And we do pretty well at getting people in. I mean, I wouldn't say last minute, but like morning of the appointment. I mean, some last minute, just depends on how badly they want to come in.
Yeah.
And then another thing that we do for to kind of prevent the no-show rate is our patients pay for their appointments before they're made. So we don't make any appointment until it's paid for. And so that does reduce the no-show fee, the no-show rate, I mean.
And do you take that by credit card? They pay online, they mail it in, anything and everything?
They pay in cash or money order. We actually only used to start it. We just started taking cash during the pandemic to prevent another point of contact. We were doing credit cards, debit cards at one point, but the fees were just so high for both us and the patients. So I'm sure we'll be looking into that again, see if we can get a better rate. But yeah, it's just cash mainly now.
So how do you handle it if you end up needing to do much more work than what they've prepaid for? Like how do you determine what their prepayment is?
We just do it because we have a flat fee for our appointments. So that Dr. Olson likes that a lot because he can do more if he wants to. He doesn't have to stop and make sure that's been paid for. He just does as much as he can.
And what's your flat fee?
$25 an appointment. Root canals and crowns are $150. Partials, are like $175 to $250, and then our dentures are $300 each arch.
Can you email that to us? Because I'm just starting. This is Frida Lust speaking, and I am just starting this process. And we did some telehealth yesterday, and we have a lot of patients who need partials and full dentures, and they're young people under the age of 60.
Oh yeah.
If you don't mind sending that to me, because we are just really struggling on how they can pay for their dentures or these procedures without any money. And we also charge a $25 fee as well. But how do you offset the cost of these larger expenses that they don't have the money to pay? It's my concern.
Of course, there's reimbursement, a lot of nice reimbursement from, the Smile 180. And then for the elderly, of course, the Smile on 60 plus. We also offer a scholarship program for patients that can apply, and they have to pay for half of their treatment, the more expensive treatment. And then we scholarship them the second half. And if they're physically able, then we ask them to volunteer at a charity of their choice to kind of work off the scholarship at a rate of, I think it's $22.50 an hour now, that they work off their scholarship.
Wow. Tell me about the Smile 180. How do you contact someone for them to help to pay for those huge expenses like that? Did you just email the director in Nashville, or?
No, Frida, it's very confusing, but there's the Smile 180 Foundation, which Delta Dental runs.
Yes.
And then there's the Smile on 60 plus. It's
right.
Two completely different programs. So the Smile 180 program funds dentures and partials. And so you have to contact Delta Dental and ask to be funded by them for that.
Okay. Well, they are already funding our clinic. We're opening up our new clinic hopefully in May, and they are funding our equipment. So I hate to go back and ask for something else, but
it's actually money from the legislature.
Is it? Okay.
The legislature gave the money to Smile 180 to administer. So they just administer that grant. It's not their money. So you don't have to feel bad, Frida.
Okay, I'll make a phone call when we finish this conference.
Okay. Now the issue with that money is that it is about to be completely all spent. And it is not currently in the budget for the legislators to replenish it. We are asking for it, but it is not currently there. So you might get an answer, well, we can't sign you up for it till it gets replenished, which would sort of make sense.
Okay,
They may not take new ones just yet, but
okay. Thank you. Thanks, Kelly, for that.
and of course, there's not, you know, the safety net money will fund the encounter to help for some of it. The Smile 180 can help pay for some of the denture. If they're a Smile On, then that can help pay for some of the denture. So you have to add it all up. You still will not cover the cost, but you'll get closer to what that lab cost is, and that's how Kelly helps determine, you know, what she needs from the patient to cover the cost of making it. So it's combining all of your funding sources to make it work.
Okay.
Which I know sounds very challenging, and yes, it is challenging to take a patchwork, but that's how you have to think about it, how to pull in all the different parts.
Thank you, Rhonda.
Yeah. Okay, anything more about scheduling, which is a difficult. Okay, so the other thing I want to talk about today, and I think Tom mentioned it already too, talking about COVID times. So, you know, the CDC came out yesterday with some new guidelines around fomite transmission as well. So, you know, at the beginning of the pandemic, we weren't sure how it was transmitted. And we were doing a lot more wiping down of surfaces and train stations and, you know, all those kinds of things. It really is difficult to transmit it from a surface. It is really, you know, the airborne is the big thing. So it's time to look at what all your policies are and think through, and also be planning going forward as more of your population is vaccinated. And knowing that some people choose not to be vaccinated, then it's sort of on them. But once it's all available, you know, it's understanding you can do what you can do to mitigate. So some of the things we're doing now, again, is we do have our lending library back in place. We are still limiting number of people in the waiting area, but we have some people in the waiting area. Just like if they're at the grocery store, they're spread out and in line and those kinds of things. So we are not having people remain in cars completely. So we're giving some more access into the building. We still have questionnaires when they come through the door, and they're still getting temperature checked and asked about symptoms and things, but also revising it so that one of the questions is, you know, have you been vaccinated? And then the questions that were around travel, of course, are different now. Like there's really no different if you're here or in Montana. So you can eliminate some of those questions on your form. So it might be time to revisit that. We've also opened it up for more people to be in the clinical area, like volunteers, to help us. So if they've been vaccinated and, you know, we give them the proper equipment, then we've got people there. We were draping a lot of different things because, you know, trying to keep the aerosol from touching walls and things, that then we would have to like wash walls and those kinds of things. But knowing that there's not that kind of transmission from surfaces, so we're relaxing some of those things as well. So it's rethinking, you know, our operatory. We also are using the suction devices. So, you know, the Octodents we have in one office, and the other office has some UV angels, which are in the ceiling that suck and clean the air. So we're not as worried about aerosols out there and those kinds of things. So, and it's case by case, kind of based on how your office is designed and what your comfort level is, but it's time to look again at those kinds of policies because they do prevent you from seeing your full capacity as to what you were before. And when I look at everybody's data, including my data, you know, we're only at about 80% of where we were pre-COVID. And you start going, so what is the reason for that? Where is the slowdown? When we look at national data, private practices are at 80-90% pre-COVID because patients aren't wanting to come in, not because of they're slower because of their policies. When we look at FQHCs and faith-based clinics nationally, they're at about 60%. So you're like, why is that? You know, that they've brought a lot of it is a lot of the staff is reallocated into doing vaccinations and things. They haven't fully staffed back. They haven't re-looked at their programming and how they can fit. I mean, you could also say that maybe private practices aren't taking the virus quite as seriously. I mean, there have not been cases where people have got the virus at the dentist, nothing traced to it. We don't have any higher incidence of COVID in dental professionals over other things. So, you know, I think it's because dentistry is really, really good at infection control. So we understood this from the beginning and we took steps and we've been successful at it. But we got to start thinking like, you know, this is the new norm. What is your new norm of the reasonable things that you're going to be doing going forward for the years to come? So I'll open that up then for thoughts, comments, things that you're doing you might want to share, or challenges you face with capacity because of COVID protocols.
Ashley? I think Ashley just joined us.
Yes, hi, how are you?
There she is. Hi. Welcome.
Okay, everybody's good on their COVID then? Okay, so talk a little bit about staffing. It's one of our challenges. We've been trying to hire 2 dental assistants for like ever, even though we've hired 2 in the last 3-4 months and 2 or 3 more front desk. You know, it just seems to be a constant challenge. So has anyone had any secret successes in recruitment? Ashley's saying no, she's trying to recruit. Tom, are you fully staffed?
Yeah, we're trying to get another dentist for 1 day a week, but we're finding now that our best source is fresh graduates. We're talking to 2 now, but they, you know, that seems to be the best option for us. We kind of zeroed in on either recent graduates or recent retirees, and the best success we've had has been in the younger ones, the recent graduates. We haven't tried to recruit any dental assistants, and we've got an arrangement with a local college to have their hygienists come and do on-the-job training, so to speak, with us. So.
Good.
I just want to jump in and alert you all that along these lines, you'll be getting an email from us not too long from now about opportunities the Department of Health is trying to draw down through grants from the federal government. And one of those big areas, pots of money that they have is to pay off loans. And I said at the time, well, my understanding is you have to be credentialed for that loan repayment program to, you know, you already have to have all your training done to be used. And they said, yeah. I said, well, would you all pay for recruitment of people from out of state? And they said, yes, which I had never heard before. Because I mean, there's only a certain pool here, and I assume everybody's trying to access that pool of various types of dental talent. But apparently it is on the table to be able to use that funding to recruit externally and to have recruitment paid for. So that's something we'll want to stay tuned and ask Dr. Lamar about on Friday, which you may or may not yet have gotten an invitation, probably not, to an urgent meeting about all this funding. So if recruiting externally would help, that might be an option.
Mary, do you know if you have to see children for dental? I know that's been the stipulation before, that we would have had to see children, and we don't. So that's never.
This is such an extraordinary thing, Kelly. I really don't know. I had a talk late Friday afternoon with Dr. Lamar, and I've been trying to, with Sarah, we've been compulsively, and actually some others are helping us, trying to formulate how to get your request back to give to them. But really everything was on the table, and it was as though, because I said, oh, I don't think that we'll have access to these funds. They look like they're HRSA funds, and that we're not set up to, they aren't for us. They're not going to give them to us. That's our experience. And she said, she didn't say exactly this, but her gist was, we will make it possible for monies to flow to you through these big pots of money. And so you should think about what you need. And I didn't hear restrictions. So again, this is all, there will be a meeting that we need to get out. We're just trying to get this information out, that there's suddenly an influx of, well, it's not there yet. They're trying to draw it down. But I think they have done it in a way that accounts for the fact that we as free and charitable care providers don't meet all the HRSA requirements. So that's part of the whole big problem, is just suspend disbelief and think about what you need. That's what the challenge will be, because we're so used to being limited and excluded, and transportation couldn't be included, or IT support, or paper, or it's kind of like, don't let anything get in your way as you're thinking how to serve. So stay tuned. This is coming. Sarah and I are working as fast as we can.
Well, and from a dental perspective, it's being united and thinking what our thoughts and requests might be. Of course, the Smile On program, which, I may be biased, but I think all of you agree has been very successful in getting care to seniors that need it, that this would be a good funnel for it. And that funding, you're all re-signing your contracts to end July 22. It could last a little bit longer than that, but like that, it would be very good timing to put that into effect to fund ongoing through these. And, then it's specifically earmarked dental and supports the work to a big extent.
Yeah, that's a great point. We know many things that have worked, and your program is a great example of an effective way to reach so many people. So, those best practices, that's what we want to have funded for sure. Keep that going.
But the loan repayment, are they thinking of doing it with TCWD, since they're the experts on the loan repayment and incentive program?
They are working with them.
Okay.
They're definitely working with them. But the request is more for, what do we need? And then they'll sort it all out. This is a big trust walk, but we're not going to be able to apply for these grants directly. So we might as well trust.
Right.
Yeah, sorry, that was a little bit distracting and
No, it's
I apologize.
it's very, very exciting. Very exciting.
Welcome to my world. I'm just like,
Yeah. Yeah. So lastly, on my list was to really be keeping everyone focused on preventistry, which is my favorite word, right? In thinking every person that we're seeing, preventing future disease. So if that's younger people, it's about HPV vaccination. If it's older people, it's about measuring or impacting their dry mouth with fluoride and supplements. It's using SDF medicine. It's using sealants on whoever and wherever, and, you know, using the new glass ionomer sealant. You don't have to etch or dry or all those things. You can put it on with your finger. It's brilliant. So there's things that are out there that we can be doing, but it's also thinking outside of our walls in how we can further participate with patients for, you know, these inexpensive things that can have real impact out there. So is anyone doing anything creative or needs more information on preventive therapies? And, you know, the preventive therapies are in the formulary that the health department wants to see us be impacting.
Hey, Rhonda, I have a question.
Yeah.
Do you guys have like a protocol for, you know, like this person is age, you know, whatever, blank to blank. And so we're looking at checking off these boxes, so to speak, as far as like, you know, HPV vaccination and, you know, sealants or whatever. Like, do you have like protocols that are written that you could share with us?
We don't, because all those things are good for anybody. I mean, they're even saying you can get your HPV vaccine up to age like 40 and things like, so we don't make things age specific in our organization. And, you know, 2 80-year-olds can be completely different as far as like health and wellness and what their needs are. So, I mean, you can put sealants on older adults, you can put SDF across the lifespan, pregnant women. So it's anyone and everyone, if that makes sense, Kelly. Okay, double check my list here. So the telehealth piece, to share that we've been using it more for post-op consults too. You know, the oral surgeons are always wanting people to come back so they can look at them, and, you know, 99 times out of 100, that was like a wasted, you know, trip. It's like trying to do that by telehealth. It is helping us quite a bit. Same with in talking to some seniors about their dentures before they come in, you know, and they're calling saying this is hurting, this is that. Just offering those kind of visits have been helpful. And then for our new patients, it's just been so helpful, even if it's just over the phone, and helping them through the paperwork and pre-registering and getting everything in order so that when they do come, that we're maximizing that appointment. So just encouragement in that area. Anyone have any teledentistry? Someone asked me, what is that? And I said, well, you take a shot and then I tell you the kind of dentistry to do on yourself, but that's really not what it is. But okay, and since most of us on the call use volunteers, any volunteer management tips, tricks you've come up with lately you want to share? We devised a new checklist sort of orientation handbook that we realized that some of our volunteers were not booked as effectively as they could have been, or you know, they didn't always know the why. I was going to offer it, so okay. So I will send it to Sarah and she can get it out to everybody. I think it's pretty good. I mean, it's specific to us, but I think there's some things in there, and the dental assistants spend a lot of time with it. So it was things they were thinking about to be helpful. I'll also share something we're working on that you might like. So we're trying to take the whole candy striper idea to the next level, but, we haven't come up with names really. It's, it's sort of like the Smile Squad, would be the level 1 candy stripers. And then we've got the Tooth Team, the level 2, and the Grin Group is the level 3s. So for pre-dental students, lay people that want to volunteer, they get to be the first level, and they're doing things in reception and check-in. And then they've done so many hours, they can advance to the second level when they get their scrub hat or their scrub pants, and they're doing their thing. And then they advance to the third level when they've had their hepatitis vaccine and TB test and those things, and they're actually helping clinically. So when we've got that fully baked, I will share it, but I think that that's kind of a good approach too, in trying to manage stuff with specific duties and roles and outlined. So hopefully that will be of use. Okay, anyone got anything fun to share?
No, except stand by, because if we can't manage to get the input from members that we need in a timely manner, I'm going to come to sort of leaders within the various communities, and you're on for dental, to say, well, how much do you think everybody needs and for what?
Yeah, well,
it's just a heart attack a minute trying to answer.
yeah, and so, when we devised the Smile On, we thought of every possible way we could do it. Like, let's give everyone $500,000, and they're our partners, we trust them, let them run with it. To people having their own, kind of bank account that we just send money directly based on when you do so much procedures and, those kind of things. And then everything sort of in between with, and we kind of approached it a little bit of everything. You got some dollars on the front end to incentivize, and then you really have to be incentivized to do the care. I think that capital things, I think we have, although we would have more capacity with capital money, but I really don't know if that money could be used for capital things, which is
We gotta let all the departments figure all that out.
yeah.
Because space was on the table in this broad sweeping conversation that we had.
Well, and we know that if you add up the capacity of the health departments and the FQHCs and the faith-based clinics, that nowhere gets there as to what the need is. But be careful what you ask for, because pretty soon Kelly will have another site, right? And so will Ashley, and so will Tom. And is that really what you want to do? And as someone that has 2 sites, it's like, be careful what you wish for. Like, it is a whole nother, team and leadership and the whole thing. So that's a challenge. There's putting everyone under one umbrella more officially is another idea too, which would, lessen some of the tracking and policy and leadership costs, which then might make it easier for much more sites. But you would lose, some autonomy if we didn't do it right.
And it's also, I agree with what you're saying. I think if we could get a little space, like if they could just get their requests in, and then we could have a little space to think, hey, does it make sense to just sort of aggregate some of this stuff at one level so everybody doesn't have to replicate, these.
Well, there's so much tracking, and like, we're piecemealing it all together now. You
Right.
create yet another one and another, audit and reporting, and
It's a nightmare, I know.
I mean,
And
it
they
really
never
is,
tell you
but,
what it's gonna be till you're done.
yeah.
Later.
And there's
So-
still not, consistent systems between the FQHCs and the faith-based either on how we piecemeal what we're doing. But I mean, we need a united sort of front around something.
No, and if we can just nail that down and get the numbers for it, we're all good. No kidding. No, these are complex issues. They are very complicated. And care is very local. And it's much more local, I think, for free and charitable providers, because you are working with the goodwill of the community to make it possible. And so that's a consensus build. You know, these things take time, and time it just, you know, and trying to pull things down isn't really happening. So how do we pull some stuff? How do we pull as much down to direct to free and charitable clinics, and then come back and process through, you know, what are the best possible ways to optimize the use of those funds for many members as opposed to just a small segment, and it being different from FQs. They know we're different. So I'm already giving them credit for knowing we're different and not expecting us to suddenly to be FQHCs as we interact with these funds. Because we're not going to suddenly be FQHCs. That's not going to be happening. Not suddenly.
Well, and Mary, are you seeing that it's repeatable funding, like ongoing?
I asked about that. I got the sense that there were, you know, and you'll see this when we get the email out, there were like 7 grants they're going for now. But I got the feeling there will be more grants coming forward, and that they would kind of take all these things, and they've come up with 3 categories they want us to think about, you know, and try to frame our request sort of within these 3 big buckets. And all that's good. It sounded like more was coming. I said, hey, it was kind of like, wow, we just have so much money suddenly, and they don't actually have it, but they see it coming, is my sense. And so what we want to do, I said, is can we put some away so that later, you know, and she said it's like a 2 to 3 year funding time frame. And they are thinking about, you know, how to not just have this wash through and be gone. You know, that sustainability is of the resources is critical, you know, and it just makes my head melt to think about all that at once. I don't know about anybody else, but they're going to think about it. They're in charge of that part. Our only part is to think about our gaps in these 3 areas. And since you all are here, I'll just tell you real quickly what the 3 areas are. Strengthening chronic disease management, addressing social determinants of health, and integrating mental and behavioral health treatment. And being creative and inclusive, and thinking that you can even have community health workers, you can ask for doctors, you can ask for reporting systems, you know, and so we're going to have to just move quickly to kind of catalog our big gaps, the barriers to addressing those gaps, and the resources to address those barriers so we can close the gaps. And it's a heavy lift. But most people know what their programs need. If you kind of get this vision of, hey, you're the trusted partner when people come to you, like you've always said, Rhonda, you know, what is the role of the dentist in identifying and managing, you know, diabetes or hypertension? You know, in so many ways, I feel like free and charitable clinics are way ahead of the private sector in understanding that that may be the one chance you have, you know, to save this person's life. Maybe it's suicide prevention. I mean, what is our role as free and charitable clinics? And
Well, but Mary, is oral health disease not a chronic illness?
It absolutely is.
So, you know, I think that's the tack to take. If it's chronic disease management, that's what we are all doing.
Exactly. And what do you need to do more, or do it better, or to be able to track your outcomes and improve your quality? I mean, this is the moment to dream into the organizations that we always wanted to have and be. And we're all doing the best we can with what we have. But if we had more, which doesn't mean we're going to get more, but we need to think that way. If we had what we really needed to do these big things, what would it be? Yeah, I did that for a couple of days too. I was just like,
well, you know, when I think of chronic disease management, you can approach it from helping people with diabetes, heart disease risk, lower their exasperated illness by improving their oral health. So, you know,
Absolutely.
addressing gum disease more than addressing tooth decay, but also addressing like being able to eat, right? So it's like addressing chewing and it's addressing gum disease in two different ways. But how do you do that in a simple, like without, you're going to get paid for every diabetes patient that you improve their outcome, right? Like that's a tracking like
Nightmare.
nightmare.
Say it.
So
Nightmare.
it's
Join
like
with me.
trying to, you know, create something that doesn't have a, you know, even though we're all doing it. But I just don't see they're going to come up with a way of.
I don't know. We just have to take this first part of the walk slowly, but quickly and slowly. Like we need to manage our expectations and really try to move quickly to articulate the gaps and what we need to do to close them for our organization, for each organization. That's going to look different for everybody.
Well, like a navigator and a dental hygienist in everybody's site that would help work with the medical side of that's doing diabetes management and the hygienist doing it, you know, and it's that kind of focus.
Yes. It's that kind of thinking, you know, like the chronic care SWAT team or this SDOH SWAT team, you know, where you have enough capacity to actually screen and refer people. And we're not the only beneficiaries, you know, there will be I think all the community organizations are being asked, but I do think that TCCN members, the free and charitable care community, has a special place in helping build healthcare capacity in the communities, and the Department of Health recognizes that. Now, how we get from the ambition to the reality, I can't problem solve it all. I mean, we've almost knocked ourselves out trying to figure out how to ask you for your needs without overwhelming you. And we may not have succeeded. we may overwhelm you yet. So stay tuned. I'm going to need to get off and drag Sarah off when this is done so we can finish getting this. I want to get it reviewed by Dr. Lamar real quickly and then get it to you.
Okay, well, we'll let you guys go in all aspects, but I think entertain the question. If you had some additional resources, like what would you do with them? What would you want to see? And, you know, could we all do it? You know, again, I think the Smile on 60 Plus, because it's already built, it's already,
That's beautiful.
Successful. We know, I think we know what the costs are, Mary. We know, you know.
Absolutely. And TCCN is not making the request. You will be making the request. So in your request, because, you know, I think it makes sense for you to make that request, that funding be targeted to sustaining that program, renewing the commitment, and boom, we know here's the budget. You know, you can just attach it. They don't expect us to have that level of detail for everything, but like you say, you have lived experience now, so you can just jump with that, you know.
Well, in the case that, you know, the safety net funding, which brought us together today for this conversation, right, does not cover the over 65 crowd. So it's a pretty good case to make. And it is in the state oral health plan to address the needs of older adults. So, you know, and the health department, you know, of course, wrote that. So
that's right.
The groundwork is there, but we need to think, and what else, right?
Yes, ma'am. And what else?
Yeah.
So put your thinking caps on. I didn't mean to interrupt this meeting, but it's also relevant. It's just kind of one thing. You know, you hear people saying, gosh, we need staffing. And then I can hear myself saying to Dr. Lamar, well, can we recruit from other states? And her saying, sure. And you'll pay for it? Yeah, put that in, you know. So I don't know how this magic will work, but I'm willing to believe. I believe.
Right.
I'm hopeful.
Right. And I believe I feel like the reporting on what you asked for would be you reporting on what you plan on doing. So I don't think they may have their own sort of reporting like they did for the safety net, but this is what we did with the money. would be by you based on what you asked for. So it's a
Yeah,
self.
but you know what we've learned, and what we don't know going into this, but we've already learned, is that if the source is federal, even though it looks really like, hey, just scoop it up and apply it appropriately, there may well be, you know, a review. They don't call it an audit, but where you go down to the receipt level. This we didn't know. I don't think the department knew it at the time. I don't think the members knew it at the time, but that is in fact what happened. And so I think everybody needs to be aware that, you know, if part of what you need to do is build systems to be able to accept money and account for money, maybe that's part of what you need to ask for. Because we haven't built these capabilities to the level that I think the state will need us to have them in the future, now and in the future. I think I just bummed everybody out, sorry. Put myself on mute.
It's going to be okay.
Really? Wow, thank you.
I mean, but
Okay, thank you.
Thank
for
you.
joining me today. You have my email, you have my cell phone
Thank you
number.
for doing this, Rhonda. You're such a wonderful leader.
No, just
You.
Yes, yes, yes.
awesome.
We
Awesome to
admire you. Love
It
you.
was good to see everybody.
Okay.
Thank
Bye
you.
now. Take
Awesome.
care.
Bye. Sarah and
Bye.
Ashley, can you stay on 1 second to look at the form real quick? Okay.
Absolutely.
Rita, I'll talk to you later. Bye, Cal.